You have emergency 911 with the address of the emergency. I need emergency. Mom, my husband is dying. My husband is dying. Come, 911, go now, please. My baby's not breathing. Okay, now, are you with him right now? He's not breathing at all. We all are with him. Oh, please, there's somebody. He's dead.
It's the AEMT lecture series. My name is Mike Morris, and I am back. Somewhat better of a voice, not quite as bad as the last video. Some housekeeping notes. We are closed till April 2nd due to the coronavirus. So everybody stay hunkered down. Limit your contact with large groups. Try to limit the spread of the virus. We will get back with you as this crisis grows. We may need to add time, or we may be okay, but we'll keep you updated. So with that being said, I'm going to put the video lecture series up online so that you'll be able to see those lectures and be able to have those available to you during the off period that we're not in class. During the lecture series for AEMT, I will not cover every slide. I will only cover the slides that have testable information and have significance to your program. However, with that being said, I would definitely review the whole chapter. And I say that because National Registry of EMTs, when you're taking the exam, all of that is open to them to test you on. I will definitely cover slides that even if I feel it's not testable, if the information seems confusing, I will try to hit that to help you out. But you when you're going through your chapter, you need to make sure that you kind of get what they're talking about. Because if you're lost in something like that, just because I'm not testing you on it does not mean that you won't, that everything's going to go great for you at registry. Because they have the ability to test questions from your EMT up to AEMT. It just varies. So with that being said, let's start today's lecture. We're going to talk about communications, right? And the definition of that, the transmission of information to another person. And verbal and nonverbal are extreme. Those are two forms of communication. Because if you look angry before you even speak, that sets the tone, and it starts the mind processing to develop opinions about who you are, where you come from, and that sort of thing. So we need to try to be as aware of our verbal. We need to be aware of our nonverbal. Effective communication is an essential component of pre-hospital care, most definitely, but not just to the patient, but to other pre-hospital care providers as well. We have to be an effective communicator, not just with the patient, but with the team that's providing care. I've mentioned this before. As an AEMT, you will more than likely be the highest level trained provider, pre-hospital care provider there at times. And it will be important not only for you to effectively communicate with the patient, but to also communicate with your team. So we're going to talk about some things there that when it comes to team concepts. Therapeutic communications. Now, this is something that you do need to know. Therapeutic Communications involves the art and skill of communicating with people on what may be their worst day of their lives. We have to be able to communicate with those folks. We need to be able to encourage the patients to express how they feel. We also, though, need to remember that we need to be able to encourage our team members to be able to speak to us and talk to us about what's going on. We're only as good as the team. And so, with that being said, I don't know if any of you guys out there have ever heard of crew resource management, but that's a big thing that we're trying to go through. Lots of departments are going to do, or they're talking about it, and some hospitals are doing the same as well, to reduce the amount of medical errors that occur every year. Crew resource management actually came from the airline industry when they were having major airline disasters where hundreds of people were being killed in airplanes that were pretty much sound airplanes, but due to pilot error and human error, it was becoming too much. And what they found was their pilots were losing their situational awareness. Or there was such a hierarchy placed in rank that co-pilots and lower ranking members of the air crew felt intimidated to speak up when they noticed problems with the aircraft, or noticed problems with decision-making processes that were being made. And so what we try to encourage you to do is, one, have a clear situational awareness of what's going on, right? Define the problem. What is the problem? Is the problem the patient's being hostile and, I'm not communicating, whatever's happening here, the patient's not hearing me. Maybe I need to step back and let somebody else talk to the patient. Or is it a problem where you just put an advanced airway in and the patient remains to appears blue, and you're thinking, well, the patient's still hypoxic. What am I doing wrong? Define those problems. When you're giving orders, clear verbalization. Dave, I need a blood sugar, and Dave should respond, okay, I'm clear. Mike, you need a blood sugar, that sort of thing. So clear verbalization with closed loop communication. All of that's important. One thing one example is, for instance, hey, Mike. Okay, so that's the attention getter. I'm Mike. You're like, hey, Mike, state the problem. The patient still appears to be blue, even though you've put an endotracheal tube in. Offer solutions. Hey, maybe we need to would you like me to reevaluate the lung sounds for you? And obtain agreement from me. And I should say, absolutely, that's a great idea. Let's do that. Let's listen to lung sounds again. So yeah. So not only do you need to be a clear and effective communicator on scene, but with the patient, but also your team. All right, let's talk about age and culture. Okay, so age, culture, and personal experiences, and what they want you to know is that it's the thoughts of people that are influenced by their personal experiences. So people are influenced by their personal experiences. It's those experiences that affect how the patient thinks. So if the patient's had poor experiences with EMS prior, then they're already in that pattern of giving you maybe some attitude because of their experiences before with pre-hospital care people. So that's something to think about when you're dealing with certain maybe a certain sect of folks that didn't receive good service. And so then they say in the slideshow here that consider using touch. Now, you can consider using touch. I think that's important. I usually use touch all the time when I first come in, but I introduce myself. Hi, my name is Mike. I'm a paramedic with the fire department. What's going on today? And so I start hearing them. And one of the first touches that I do is I'll reach down and reach for a radial pulse, because the radial pulse is going to tell me a lot that's going on. It's very objective. It's going to tell me, one, their blood pressure, if it's present, then their pressure is above 90. It's going to tell me the rate. If their heart rate's fast, I'm going to, find out real quick that that's not normal. And I could be dealing with a lot of different things, cardiac emergency. I could be dealing with someone who's in hypovolemic shock. So that heart rate tells me a lot. And I'm able to touch the person. And so there's a connection there. But what you have to be careful, though, is of age groups. I can't do that same thing with a 2-year-old because they do not want to be touched. I can't proceed in the same manner with a middle age group. A middle age group sect, they need to develop a sense of trust before you start laying hands on them. So I might talk to them a little bit longer before I go in for the radial pulse. I may, hi, my name's Mike. I'm a paramedic with the fire department. What's going on today? Start hearing their story. I may, ask a couple of closed questions, so I don't get like a 10-minute response. And then once that's been opened up, then I'll go in. But also don't forget too that a lot of the trust that's built is based on what your appearance is. You can I do this, and I'm not the only one. I have a friend of mine that works with me at my part-time job at a ER, and we sit back a lot of times and we'll watch EMS folks come in the door, and we'll go, yep, that's what I'm talking about. And when I say that, it's usually because it's somebody that looks like they just rolled out of bed, but it's 2:00 in the afternoon, right? So professionalism goes a long ways by how you're dressed. Is your t-shirt tucked in? If you're going, if you're out and about responding on calls, you're in your station t-shirt, is it a t-shirt that's 20 years old, right? Is it a t-shirt that's got holes in it? You need to be presentable. Have your t-shirt tucked in, if nothing else, but look presentable. Look like a professional. So, family, friends, and bystanders, here again, we need their trust as well, because they will help sometimes on difficult patients who are non-trusting of you. They will help by just watching how the patient will watch how they respond to you. And if they respond favorably to you, chances are really good that the patient will eventually start having more trust in you. So it's how you communicate with them too. You communicate with them professionally as well. You need to be careful when speaking to the family members about the patient because the patient may misunderstood something that you said. So, it's okay to interview the bystanders, and sometimes we don't have a choice. But if it's something that you need to say that might be misinterpreted by the patient, it may be a good time to ask that family to step outside so you can ask your question. And then communicating with children. So we're going to encourage a parent or caregiver to be involved with that child's care. Again, once the child sees that that caregiver is giving you trust, it will help to gain the trust of the child as well. If the child's crying or something like that, and the caregiver can hold the child, even better. I always try to do my cross the room assessment while the patient's being cared for by the caregiver. I've had many times the caregivers tried to hand me their child, and I'll tell them no, you hold them because I don't need them crying yet. I want to listen. I want to listen to them. I want to observe them for a little while and see how they're breathing before they get upset. Now, of course, that changes if you get there and the child has altered mental status, appears lifeless, then go ahead and give me that baby. But so our communications are not only with other pre-hospital care providers and also the patient, the bystanders. We've got other folks to think about. And that would be other medical professionals, right? The hospital, medical control. So we need to communicate clearly there as well. If you're not acting under your protocol, or you are acting under your protocol, and your protocol tells you to contact medical control, you're requesting orders or receiving orders, you should use closed loop communication. You should repeat that drug order back. Okay, Med 23, I'm clear. We're going to administer 1 milligram of atropine IV push. So I'm going to repeat that back to them. For some reason, it kind of goes without saying, but I'll say it anyway. If you're online with medical control and some type of communication failure happens and you're unable to receive your orders for your medications, you're still under your protocol. If your protocol says you can administer it, go ahead. But if not, you got to call them back. You have to get orders. All right, so when we're talking about communicating with hospitals again, and we're talking about turning the patient over to the hospital, we need to make sure that we give a verbal report and a thorough report. So we know from the previous video that I posted that patient the EMS crew didn't give a good verbal report other than the patient's ETOH, and he got miscategorized. So we need to make sure that when we're giving those verbal reports that they're thorough. To transfer the patient, it doesn't, it's not official unless a verbal report is given. All right, so you'll have nurses that are like, I don't need to hear it, I'll just sign. It's okay, hey, no problem with that. If you're refusing it, that's fine. I'm going to document that you refused the verbal report. And I've had nurses say, okay, I don't care. And hey, it's on them. If they just do not want to listen, you can't make them listen. Right? But, you have to cover yourself because, if something bad happens to that patient, I promise you, they're going to want to know why a verbal report wasn't given. Special situations. So when you're dealing with mass casualty incidents, we need to make sure, and this kind of goes with talking with dispatch, dispatch is appropriate to check the status of receiving facilities for the number of patients that they can receive, or what their status is on their trauma status and that sort of thing. It's really not appropriate to give the dispatcher your medical report and have them call the hospital for you. Now, I have had problems at certain hospitals, couldn't get anybody on the phone, and I was en route with a cardiac arrest. And I'm like, hey, radio, call so-and-so and tell them we're about 5 minutes out. We have a cardiac arrest. And that's really all that needs to be said. I'm not requesting orders. I'm working clearly under my protocols. I just am trying to get them ready. All right, we're going to talk about documentation next, and we talk about legal issues of a PCR. And I think that a couple of things should be no-brainers. One, and it doesn't really apply to us too much anymore because everything's computerized here. Once you hit submit, you can get a PCR back to document, but it automatically shows that you're doing a late entry. But we don't want to go back and try to change something that's in the report to make us look favorable. That we just can't do that. The other thing is when we are documenting, we can't have biases. People will figure out biases all day long by reading your report. But we do need to document objectively. Okay, meaning if the patient is, you smell alcohol, all right, then document that. You can document there's a smell of ETOH. If there's a behavior that go with that, you can document that behavior. But be very careful not to be documenting that the patient is drunk, because we don't know that. We can't do a blood alcohol test. Be careful when you're documenting such things, because they will have a field day with your patient care report. They'll want to know where you went to school and received your training to diagnose someone as being intoxicated. So yeah, you got to be careful with that kind of stuff. Just document the objectives, what the finding is. When we're documenting in the narrative again, document medical terminology, only using standard medical abbreviations. Okay, only standard medical abbreviations. So if you don't know what the abbreviation is for something, then write it out. Don't guess. Also, you should include pertinent negatives. Okay, and remember what pertinent negatives are. All right, there are signs and symptoms that are expected to be present that aren't present. Migraine headache without light sensitivity, because most of the time that's present. So that would be a pertinent negative. So what's the most significant consequence of a poorly written patient care report? Well, I think the worst thing is that subsequent care that the patient would receive would not be inappropriate. They may be going off your patient care report, reading something in your narrative, and get tunnel visioned on that and administer a treatment to the patient that the patient didn't need because of poor documentation. So special cases to report. There's all kinds, like gunshot wounds, right? Some infectious diseases. But I want you to focus on dog bites because they are a big deal nowadays. We need to make sure if you get an animal bite that you contact animal control so that they can make a report on that dog bite. All right, guys, I think that's going to be it. I should have also said, so this is chapter 5. Chapter 4 is about terminology, right? I'm not putting a lecture up for that because there's really, not a whole lot for me to talk about. But I am going to put out a PDF worksheet and some information. I will tell you this, we will work on that in different labs because this is a big problem for AEMT students testing. They test you guys a lot in medical terminology. So we need to be ready for that. And so I think the best thing to do is just to give you a little something to prepare you for it, like worksheets and that sort of thing. I don't think a lecture is going to help in that because there's really just not a good lecture for it. All right, that's going to be it. I will see you guys in the next chapter.